احنا بقى هنبتدي نخش في العلم شويه، ويمكن عشان انا من زمان كنت بحضر مؤتمرات النيوروماسكولار ديس اوردرز، فدايما الساينس هو كان الاساس وهو اللي كان بيدخلنا في العلاجات دي. فانا هدخلكم النهارده في التو بلينري ليكتشرز اللي انا بعتز بيهم جدا. اول بلينري ليكتشر كانت هتبقى الدكتوره علا علي خليفه. دكتوره علا علي خليفه هي بروفيسور كونسلتنت كلينيكال جينيتكس عين شمس، وهي الدايركتور اوف ذا جينيتك يونت بيدياتريك ديبارتمنت عين شمس يونيفرسيتي. ويمكن هقول نبذه صغيره ان والدها دكتور علي خليفه، وده كان استاذ البايوكيمستري عندنا في عين شمس، وهو الاب الروحي لينا كلنا، هو اللي كان بيعلمنا قبل البايوكيمستري، هو اللي كان بيعلمنا الاسكس وحب البلد وحب بعض، وهو اول واحد دخل دلالات الاورام في مصر. جاب منحه تقريبا من هولندا يا علا، وعمل معمل رائع في عين شمس، ومن بعدها كل معامل الدلالات الاورام قامت على شغل دكتوره علي خليفه. طبعا اكتشفت ان دكتوره علا سافرت بره وتعلمت شغل رائع، وكانت في السعوديه مستشفى فيصل التخصصي، عملت هناك ابحاث رائعه، وبعدين قررت بقى ترجع مصر. علا هتنضم للتيم بتاعنا بتاع النيوروماسكولار ديس اوردرز، وهتقدم لنا شغلها على الميتابوليك ديس اوردر. طبعا انا بطلب بقى من التشيرز بتوعنا، معرفش دكتور عادل حسنين جه، دكتور محمود عبد المعطي رئيس قسم الاعصاب في الازهر، دكتور ساهر هاشم انا كلمته بس بتهيألي هو ما قدرش يجي، ولا دكتور انور اتربي، دكتوره ناهد صلاح ما جاتش، محدش عايز خالص يخش في الميتابوليك. استاذ دكتور طه منورنا النهارده، دكتور طه مش عايز يطلع معانا خالص. دكتور طه يا فندم ده موضوع والله بتاع حضرتك، اتفضل يا فندم. دكتور ايمن ناصف بعد اذنك لو سمحت، هتسمع علم مش قادره اقول لك المحاضره النهارده، انا قدمتها بس انتوا هتقدموها تاني. اتفضل يا دكتور ايمن، اتفضل يا دكتور طه.
كويس قوي.
الحقيقه انا بشكر استاذ دكتوره ناجيه for giving me opportunity ان انا to share في الجريت scientific gathering. يعني انا بشكر كمان التشير بيرسونز وبشكر الجريت اودينس. الحقيقه topic which I show today that already foresee metabolic unlock the mystery, it will not be covered in 30 minutes. بس أنا already according to للثيم بتاع الكونفرنس أنا I gathered الكيسز اللي could suit مع already theme today. I want to start to show this video. Already خلال شهرين I faced those two separate cases. The first case can already a 14-year-old boy who was clinically perfectly attending regular school. Then he starts to have 6 months back to the presentation to the clinic, frequent falling, and then followed by spastic paraplegia as it is evidenced. The second one is another patient, also 16-year-old who was perfectly normal, and then also the same scenario 6 months back to the presentation. He was perfectly normal with no symptoms or signs of any disease, and then he starts all of a sudden to have frequent falls again, and then jumped into spasticity of both lower limbs. The third case, this girl is 11 years old, had a history, a long history of problems which was started at the age of 6 years, and then I'll focus today on a full description for the clinical scenario of her. All those 3 cases proved to be heritable or to be treatable disorders. So if when facing a patient with spastic paraplegia, most important, مهم جدا ان احنا to search for a treatable mimics, because already treatable mimics of hereditary spastic paraplegia, they do have a heterogeneous course, which were very difficult to have a differential diagnosis between them. So very important, as I'll show in the coming slides, how we can briefly have a good investigations and then to focus on the triple one, because as all you know about the metabolic disorders, time is very important. يعني الوقت من once ان احنا we saw the case to the start of treatment, very crucial for the quality of life of those patients. So my presentation flow charts will be a background on hereditary spastic paraplegia, and then I'll pass by treatable inborn errors of metabolism mimics. Then I'll put a diagnostic approach, and then I'll jump into a case scenario. Hereditary spastic paraplegia, also called the familial spastic paraplegia, was initially referred to as the Strample-Lawrence disease, a name given for the two physicians who in the late 19th century independently described the key features of spastic paraplegia. It has become evident that hereditary spastic paraplegia is not one disease, but a mixed group of genetically heterogeneous conditions that result in broadly overlapping clinical features. وده already ده المين part أو الدور بتاعنا إن إحنا early to detect when referred لينا في الكلينيك a case of spastic paraplegia, we have to roll first a treatable disorders. Those disorders, they are characterized primarily by progressive degeneration of the corticospinal tract, and clinically they present with lower limb spasticity and weakness. And this will be, the patient will succumb then to abnormal gait. They are classified clinically into pure forms, that is to say, if spastic paraplegia with bladder involvement is the only clinical findings, and the complicated or complex form if they are additional neurological or systemic abnormalities. Clinical manifestations, I've said before, get impairment along with other corticospinal signs. Bladder dysfunction is relatively common in hereditary spastic paraplegia. For the diagnosis, which is the most important and very crucial part, and this is the main for my presentation today, is that the characteristic clinical manifestations are very important. We have to have a full history taking, important to have a full even dietary history, because when I'll show in the slides, there is a urea cycle disorders can have a mimics. So we can see there is by history, there is history of protein aversion, which will be minor if I'm not taking details. So I have to have a full details from the parents, and usually بالexperience بنلاقي واحد either الfather أو المother هو اللي can give full history. فلازم ناخد full history in details. We have asked about في already a protein aversion or not, في history of headache when they are taking proteins, في history vomiting, and blindly نقولوا فعلا الأولاد دول كانوا فعلا بيرفضوا إن هم ياخدوا التشيكن أو بياخدوا الأكل اللي فيه high protein، وهم يبتدي يعملوا already self aversion to this food. Then a family history, 3-level family degree, very important. The exclusion of other disorders, as I've said, treatable important errors of metabolism mimics is the most important. And increasingly on molecular genetic testing then to confirm a diagnosis. When evaluating a patient with hereditary spastic paraplegia, the possibility of hereditary spastic paraplegia mimics should be considered, as I've said, in the setting of a typical clinical course and the symptomatology. The metabolic mimics, they tend to have what? More accelerated course. يبقى احنا ما ناخد نسأل على الكورس نلاقي more accelerated course، نلاقي already كمان coexistence of symptoms، ممكن نلاقي already cognitive impairment، نلاقي already deafness، نلاقي visual affection and other symptoms. This could alert us that we have to think about the treatable mimics, which should be excluded. Inborn errors of metabolism represents a rare and often unappreciated cause of spastic paraplegia in children and adults. motor neurons and the corticospinal tract with their long axons and the high energy demand seems particularly vulnerable to the metabolic defect. And this is the causes which attribute to those patients having the same clinical phenotype like hereditary spastic paraplegia. And because the high energy demands which are lacking, so there is affection. Important errors metabolism can therefore lead to phenotypes that resembles more commonly complex forms of hereditary spastic paraplegia. Inherited metabolic mimic disease, I'll put some examples which is related to spastic paraplegia. Severe 5-10 methylene tetrahydrofolate reductase deficiency. This leads one of the disorders which important errors which leads to inavailability of 5-methylene tetrahydrofolate, and therefore there is methionine synthase not adequate. And then methionine is not available. For this reason, the patients commonly present in the childhood period, and they can succumb into regression of previously acquired milestones. They also can have spastic paraplegia if not recognized early and treated promptly. And this will be the discussion of one of the cases which I'll show, case 3, and we'll discuss in details. Also, late onset copalamin C deficiency type in adult with cognitive impairment and behavioral disturbance and significant cortical atrophy and cerebral damage in the MRI. We have to know that copalamin C, or it is known as combined methylmalonic acidemia and homocystinuria, this is the most common type of inherited copalamin deficiency. And those patients who do have an early neonatal form and a late form. A late form could be juvenile or adult. Juvenile or adult forms, if untreated patients, they also can succumb into cognitive impairment, into degeneration of the lateral and dorsal spinal cord, and they do have spastic paraplegia. So I have to think about this disorder when I'll say by doing the relevant investigations when I'm thinking again for the spastic paraplegia. Arginase deficiency in patients diagnosed initially with hereditary spastic paraplegia. All of us knew that the urea cycle disorders, they do have deficiency either in urea cycle enzymes or transporter defect. So the arginase deficiency is one of the enzymes which is deficient leading to arginase deficiency, and those patients usually we saw them in the neurology clinic. They have been mistaken for cerebral palsy. If not diagnosed early, those patients can succumb into spasticity, and usually the presenting age 2 to 4 years of age. And also there is a rare presentation which happened also in adulthood with spasticity. But those patients is different from cerebral palsy when we took history by the course of the disease and also by the presence of high ammonia and not high ammonia for those patients. This is arginase is the only urea cycle disorders which rarely we saw them in the ER because those patients don't succumb into critical hyperammonemia, but they can do have elevated ammonia, but not that high like the other enzymes of the urea cycle. Also corticospinal damage in triple H syndrome. Triple H syndrome also, this is one of the urea cycle disorders, the transporter defect. Triple H stands for hyperammonemia, hyperornithemia, and homocystinuria syndrome. And those patients also, 92% of presentations in the juvenile or adult, and usually present with a decreased decline in cognition. They also had attacks of moderate hyperammonemia, and if left untreated, also spastic paraplegia. And those patients very important to diagnose them early and treat to guard against the complications. GLUT1 deficiency, glucose transporter deficiency, by those patients, they do have no glucose in the CSF, which is very important for the energy. And then those patients can having microcephaly, they can have also several problems, including spastic paraplegia, and very important to be diagnosed early. And there is a great role for ketogenic diet for those patients. They do have also seizure. Also, spinal xanthomatous disease. These disorders, they do have xanthomatous, which can be identifiable clinically. And also, they do have early cataract, and they do have diarrhea. This is one from the treatable mimics we diagnosed if we have good clinical examination for those patients. Dopa responsive seizure, BH4 deficiency also is one of the disorders. If we didn't treat early, can succumb into hereditary spastic paraplegia. Biotinidase deficiency, it is a treatable cause also of hereditary spastic paraplegia, and also in patients who are having a profound deficiency, that's to say less than 10% of enzyme activity, they can succumb into so what about a diagnostic approach? This is the most important, ده المهم اللي احنا in our clinic. If we face the patient with spastic paraplegia, first I have to think about the mimics. As I've said, a typical clinical course or symptomatology. Then investigation required the basic. First I have to roll out the acquired cause like spinal cord infection, like vitamin D, vitamin B12, or copper deficiency. So I have to order brain and cervical spine MRI, vitamin B12, copper, zinc, CSF, autoimmune biomarkers. And then if all proved to be normal, acquired causes has been rolled out, I have to give a trial with levodopa. And then according to the type of genetics, that's to say autosomal dominant recessive or X-linked, and the mode of inheritance, I will then categorize the types. Childhood onset in X-linked, I have to think about X-linked adrenal leukodystrophy, which has 3 phenotypes, but the one do have increased very long chain fatty acids, so I have to send for order, and then to confirm by ABCD1 gene testing. For autosomal dominant form, in case of citrulline, which was low during fasting, I have to think of B5 CS deficiency, and also I have to do CSF glucose to roll out GLUT deficiency. Autosomal recessive, as I've said, I have to think of combined methylmalonic acidemia and homocystinuria, arginase, and also to order total homocysteine, to think about biotinidase, to order biotinidase activity, and then to do amino acids for arginine, also to do homocitrulline for triple H syndrome, and also cholesterol, and then methylmalonic acid for also combined methylmalonic acidemia and homocystinuria. For adolescent adult onset, if autosomal dominant, I have to know that in case of GLUT, there is autosomal dominant can be manifested in the childhood or adolescence. So again, CSF glucose in the same time, I have to take sample plasma to compare, and then autosomal recessive, again the same for adulthood, the same for presentation with autosomal dominant and the recessive, for autosomal recessive in the childhood and adolescent. If investigations for hereditary spastic paraplegia mimics turns to be negative, I have to consider next generation sequencing, whether WES or whole genome or a specific panel. So just to summarize what I've said, for the cases, the 2 boys which came to me in the clinic, the 14 and 16-year-old, they came after the investigation to have triple H syndrome biochemically, and they confirmed biochemically and molecularly biopositive pathogenic vein SLC 25A15 gene, and then as I can show you, this is a patient which I told you was perfectly normal, and then this هو العيان before he started to have a problem, and all of a sudden he deteriorate to have this form of spastic paraplegia. وطبعا البيشنت ده already doing physiotherapy. أستاذة الدكتورة ناجي أنا already refer to her على أساس will help for relieving the spasticity. The other patients also case 2 the same. Already a 16-year-old boy, and he was perfectly normal, was also based on biochemical and confirmed molecular to have triple H syndrome. In those patients, we have to start by having a restriction of protein to the safe level of protein intake, and also those patients have to have ammonia scavenger medications because even the patient had diagnosed late, they do have a spastic paraplegia. I have to start treatment to stop the progression of the disease and to maintain a steady level of ammonia level, because those patients used to have a moderate or mild to moderate ammonia level, which can affect the cognitive function. So initially, the patient's IQ was around 70, and then with the start of treatment, the patient's improving with better IQ, and also relieving spasticity symptomatically. But the most crucial or most important that we have not to say that خلاص البيشنت بقى spastic. No, we have to start to treat. We have to do a strict for ammonia management by Day3. Case 3, I wanted to have just a full description of the case. This is a girl which came also in the clinic. She was a 12-year-old, second in order of birth of marriage, full spontaneous vaginal delivery, birth weight 3.5 kg, normal development at 5 years of age. The family to have unsteady gait, frequent falling at 10 years of age, insidious of abnormal gait, poor school performance, cognition, urinary incontinence, episodes, visual hallucination, behavioral changes. This was an excellent one at the school. She starts to have deterioration by that history. Parents sought medical advice and referred to our clinic. Physical, the weight 95th centile, of 5th centile, chest cardiovascular, abdominal examination, all unremarked neurological spasticity and exaggerated deep tendon reflexes involving both lower limbs, exaggerated plantar response, normal cranial nerve examination, intact sensory, upper limbs normal. We did ABG normal, ancillary test for CBCD, ammonia, lactate, random blood sugar, liver function, renal profile, hepatic profile, all within normal. Then we ordered the tandem. It shows C3.5 and C3C2 ratio 0.24 and methionine 3.5. Urinary organic acid were unremarkable. Plasma MMA was 0.3. Plasma folic acid and B12 unremarkable. Plasma total homocysteine was 288 micromole per liter, was strikingly high. Pelvic abdominal ultrasound and ophthalmology and echo unremarkable. Imaging showing chronic demyelinating peripheral sensory motor polyneuropathy with sensory axonal pathology. Brain MRI at 5 years unremarkable, at 10 years showing brain atrophic changes, bilateral periventricular areas of abnormal signal, likely demyelinating process, which was characteristic for those patients. And as we can see, MRI findings, this was a girl was before spasticity and before deterioration, and she was perfectly normal, and then succumbed into the abnormality, as we can see. So the suspected diagnosis based on a later childhood spastic paraplegia, abnormal behavior, cognitive decline with increased total homocysteine, decreased methionine, normal MMA, MRI brain with white matter changes. We suspect a treatable mimics of hereditary spastic paraplegia, methylene tetrahydrofolate reductase deficiency, and then we ordered the genetic testing to confirm diagnosis and came with a homozygous VUS was identified in methylene tetrahydrofolate reductase gene. What I'll show to the, I'll not move into details for the disease, but I have to say that for the older infant and the children, they frequently manifest with seizure, cognitive impairment, and with increasing age, there is increasing spasticity. I'll move quickly here to say that folic acid may exacerbate those disorders. So very important when you are taking the treatment, we have to start those patients on folic acid, and a recommended treatment as shown, drugs with proven clinical benefits between anhydrous, which is a methyl donor for remethylation process, and the treatment without proven benefit for those patients, folinic acid, L-carnitine and methionine. And to be avoided, I showed in red, we have tried an emergency letter for those patients to avoid the nitrous oxide and also folic acid and the protein restriction. And nitrous oxide, because it's also causing abolishing for the B12, and folic acid, no role for folic acid because already the fact after that, so they benefit from folinic acid, and also protein restriction because those patients, in contrary, for the patients with copalamin, for the patients with classical homocystinuria, you do have low methionine, so those patients don't need any diet restriction and can have a regular diet. And by starting between 100 milligram per kg per day divided by ID increased to 250 milligram per kg per kg, 12 grams per day with no diet restriction. We showed rapid and sustained decline total homocysteine 50 to 70% and elevated methionine to normal age. Plasma total homocysteine was initially 288, which was raised to going down 155, 145, and the last visit 114 micromole per liter, and the great improvement of behavioral pattern, attention and executive functions noted, rapid and sustained decline in total homocysteine over 2 years, additional cognitive improvement, cognition improvement, no more urinary incontinence, and the clear expressive language. In conclusion, I want to say that hereditary spastic paraplegia has a heterogeneous clinical profile and a broad differential diagnosis, including neurometabolic disorders that are potentially treatable. Raising awareness of such disorders could significantly improve the patient outcome and the clinician's perspective by allowing a timely initiation of target treatment. And I wanted to give this take-home message not only for spastic paraplegia, but for all important areas of metabolism, that time is highly beneficial. So we have to raise an awareness to have increased a high index of suspicion. And I want to say that thinking metabolic and the prompt recognition together with proper treatment will have a great impact on quality of life of those patients. And I'd like to thank you all for that.
بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. طبعا أنا مبسوط إن أنا بينكم النهاردة، وبشكر الأستاذة الدكتورة ناجية على البروجريس اللي احنا فيه دايما، وببقى سعيد إن أنا يعني في كل سنة بلاقي حاجة جديدة وناس جديدة، وأنا بشكر الأستاذة الدكتورة علا إنها معانا دلوقتي المحاضرة الجميلة دي. طبعا يعني إن شاء الله يعني احنا عايزين بروجريس والتعاون يبقى متبادل بين الجامعات كلها وبيننا وبين الوزارة. والأهم من ده برضو شركات الأدوية، يعني أنا مبسوط إن هم معانا، ويعني أدعوهم إن هم يعملوا الصناعة عندنا برضو، يعني يحاولوا الحاجات دي لما هتبقى في مصر هتبقى أرخص، وده هيبقى حاجة جميلة أولا. وبعدين احنا يعني مصب للشرق الأوسط والبلاد النامية، فهتبقى أرخص وهتبقى أحسن يعني. طبعا المحاضرة بتاعت حضرتك هايلة جدا. طب بس الحالات دي مبقاش فيها سكين تشينجز أو حاجة يعني حاجة باينة كجنرال اكزامينيشن، عشان اتفرق بينها وبين الهيريديتاري سبيستيك.
اللي قلت لحضرتك لو بالنسبه للتريتبل ميمكس الاونلي بالاكزامينيشن السريبروتندينيوس ديزيز ان احنا ممكن نلاقي التانسومز وايرلي كاتراكت، لكن اكشولي اما يجي لي بيشنت ويز سباستيك بارالبليجيا فيري هارد ان انا اقول سبيسيفيك. لازم زي الالجوريزم فور انفستيجيشن I have to roll first the acquired causes and then I'll move into investigations for a treatable mimics and then I'll jump into a molecular for early diagnosis and the time يعني constraint for those patients.
ميرسي قوي دكتوره على المحاضره الرائعه دي. هو كنت عايز اسال حضرتك بس هل في معامل ممكن تعمل سكريننج ميتابوليك سكريننج للحاجات دي؟ يعني احنا جاست نفكر ان الموضوع ده ممكن يكون ميتابوليك.
كويس ان حضرتك برضه قلت حاجه للسكريننج.
بصراحه بنلاقي المعامل قليله قوي يعني.
لا حضرتك قلت سكريننج ده فيري امبورتنت. ان انا مثلا البيشنت اللي diagnosed at the age say 16 years she do have a younger سيب اصغر منها، بنعمل targeted mutation analysis للبيشنتس دول على اساس ان انا لو كانت بوزيتيف I'll start treatment. زي حضرتك اكس لينكد ادرينال ليكوديستروفي نفس الكلام. يبقى اول حاجه يبقى دول بنقول دايما الكبير اللي هو الكبش الفدا او بيحصل فيه البروبلم، بس انا لازم وانس يكون عندي موليكولر لازم اي هاف تو سكرين الاذر ممبرز اللي هم، لان اي دونت نو زي ما قلت لحضرتك البرزنتيشن بتبقى هيتراجينس regarding الايج اوف onset regarding الديزيز سيفيريتي even intra and intrafamiliar phenotypic variability or variability in the clinical phenotype between even two SIBs having the same genetic abnormality.
انا كمان اقصد ان انا في الانفستيجيشن يعني هل في معامل ممكن انا جاست ان انا افكر ان ده يكون ميتابوليك ديس اوردر ابعت العيان يعمل ميتابوليك سكريننج لمعظم الديس اوردرز دي، ففي كان في معامل موجوده كده تقدر تعمل الاوبشن؟
طبعا انيشيالي مثلا حضرتك يعني احنا في وزاره الصحه بيبقى التاندم، وعندنا اوريدي موجود عندنا في الديبارتمنت اوف ميديكال جينيتكس بنعمل اوريدي تاندم ماس سبكترومتري، بنعمل عندنا في الميديكال جينيتك ديبارتمنت في الامونيا وفي اوريدي اللاكتيت. لو انا فكر ولو انا عايزه كوانتيتيف امينو اسيد برضه ممكن اي كان سند للبيشنتس افيلبل وفي فارماجين وفي اذر لابس. لازم مهم جدا الانتربريتيشن، ده اللي انا احب اقوله، ان يبقى في ريفرنس لاب يبقى في جود انتربريتيشن، لان ده هيورينا احنا رحنا فين او جينا منين. لو عندي لاب وانا تراست الريزلت بتاعته الانتربريتيشن بتاعته كانت نوت جود دي فيري باد. ومهم جدا زي سترينث اللي حضراتكم ان لما باجي بالنسبه للسامبلز بالنسبه للتوتال هوموسيستين لازم سبيشال بريكوشنز للسامبل، فلازم برضه ابقى عارفه اللابز يبقى عارف هاو ذي كان دو الريزلت اوف توتال هوموسيستين، لان اوريدي السامبلز هاز تو بي اكستراكتد وهاو ذي هاف تو ورك اون ات، واوريدي لازم يبقى في سبيشال بريكوشنز بالنسبه للتوتال هوموسيستين. ذا سيم فور امونيا، الامونيا لازم يبقى عندي الفري فلوينج سامبلز افويد التورنيكي، لازم تكون الريزلت ويزن 30 مينتس. يعني في حاجات كتيره لازم تو بي كونسيدرد.
دكتوره ناجي عايزه تعلق؟ اتفضلي.
الحقيقه انا عايزه اعلق على كده، لان يمكن في سببين خلوني اطلب من دكتوره علا ان هي تبقى معانا النهارده في النيورولوجي والنيورو ماسكولار كونفرنسز. اول حاجه حالات الهيريديتاري سباستيك باراباريسيس سواء في الاطفال او الكبار، دول بيجوا لنا كتير في الكلينكس سواء نيورولوجي او في النيورو ماسكولار، واحنا بنقول عليهم ديجنراتيف، ويا اما نقدر نعمل لهم جينيتكس يا اما ما نقدرش. انا طبعا اكتشفت بعد الحالات اللي اتعاونت فيها مع الدكتوره علا I was completely wrong، وبدات اطلب بقى من يعني زمايلي في الوحده، لا انا هبعتهم للميتابوليك يونت الدكتوره علا هي تعمل اسسمنت بنفسها. كمان المعامل اللي هي الكوميرشال زي ما هي الدكتوره علا كده بتقول ممكن الامونيا يتعاملوا معاها غلط، فانا مش هثق في معامل كوميرشال. انا ابعت الاول اسسمنت ميتابوليك يونت زمايلنا سواء عين شمس او ابو الريش او الازهر او الاقاليم، عندهم لازم حد متخصص يعمل تقييم ويقول. زي ما مثلا لقينا حالات الدوبا ريسبونسيف ديستونيا، احنا فاكرين دول سي بي او فاكرين دول هيريديتاري سباستيك باراباريسيس، وبعدين بنبتدي نديهم سمول دوز دوبا، نبتدي سمول دوز سينيمات، نلاقيهم تاني يوم جايين ماشيين. يبقى دي حاجات تانية. تالت بقى حاجه مهمه جدا، التريتابل دول لازم نلحقهم بدري. يعني الطفله دي اللي عندها كوجنيتيف اسسمنت وسباستيستي، كل ما هدي الدواء بدري، وفي بعض الحالات يمكن هتقولي هي على اخر حاجه، في بعض الحالات مجرد تظبط له اكله، يعني هي خلاص عملت جينيتكس وعرفت ان جين ميوتيشن، ظبطت له الاكل بتاعه او اديته certain amount of vitamins داخله في الباس واي، هتظبط لي العيان كلينيكالي حتى لو عنده جينيتك ميوتيشن. هطلب منها بس هتقول لكم في 5 ثواني اخر عيان بعته لها عملت فيه ايه.
انا لسه كنت هتكلم عليه. الاستاذ دكتوره ناجيه كلمتني من حوالي 3 ويكس كده على هو 39 year old male كان referred previously ان هو already started by history frequent falling, or he does have also abnormality in climbing the stairs. وابتدى البيشنت دول راح multi disciplinary team و they started him a huge number of steroids, وبعدين البيشنت didn't show any improvement, وللاسف بعد كده deteriorated ما كانش بيقدر even to do even الهوم كورس او to go from bed. ايوه بالظبط exactly. وبعدين البيشنت ده استاذ دكتوره ناجيه جت she told me ان بعتت لي already الميوتيشن. البيشنت ده some of the physician did for him testing was positive for genetic diagnosis of glutaric aciduria type 2 الميوباثيك late onset form. الحقيقه انا from my experience I do have young same scenario. كان already one boy referred برضه to me للكلينيك كان around the age of 5 years, وهو already كان الولد ده once ان يجي له attacks زي الفيفر او already other than الفيفر مثلا going to have high stress related to exercise كان الولد ده بيبقى bedridden. وزي told me ان الولد ده كان we did for him tandem urine organic acid in between الاتاك كان completely perfect. فبعدين الولد ده جالي كان already كان في severe decompensation. I ordered for him التاندم والurine organic acid and it came positive for glutaric aciduria type 2. The same scenario for the patient دكتورة ناجية أستاذ دكتورة ناجية بعتته. البيشنت ده already I started him on riboflavin. already البروبلم في الجلوتاريك aciduria type 2 ان المين already thing and we have to give a riboflavin لأن already بنسميها multiple acyl CoA dehydrogenase deficiency. فبيحتاجوا already riboflavin. once ان ابتدى التريتمنت on a huge dose together with coenzyme Q10 together with carnitine بيبقوا perfectly normal. بياخدوا already around 5 to 6 weeks. انا لسه كنت عايزه اوري لحضرتك العيان جالي اول امبارح في الكلينيك.
لا هو الاول حضرتك جالك بسيفير مايوباثي
جالي طبعا كان
respiratory distress and bulbar symptoms, وكان بيتعالج على انه قبل كده انفلاماتوري قاعدين يدوا ستيرويدز، فالبيشنت ماركتلي ديتيريوريتد. لكن one of the professors الحقيقه هو اللي كان عمل له الميوتيشن، ولقينا الميوتيشن. بعت لها في ساعتها قالت لي ابعتي لي العيان ده يتحسن. العيان markedly improved on riboflavin therapy.
احسن حاجه قالها لي يا استاذ دكتوره ناجيه ان انا بشكر ربنا سبحانه وتعالى ان انا قدرت اسجد وانا بصلي. بيقول لي ما كانش بيعرف يتكلم، ابتدى بيقول لي يتكلم، كان بياخد كل الاكل منسد مش عارف اوريدي تو كف. بيقول لي يا دكتوره علا انا ابتديت كل ده كأن ما كانش عندي الحمد لله. قلت له انت كمان هتتحسن اكتر واكتر ان شاء الله. كان هو بيروح الكليه في كليه تجاره قعد لغايه سنه ثانيه، وقال لي ان هو كان اخوه بيوديه بالعربيه ويجيبه، ما بيقدرش يمشي ما بيقدرش يتحرك. فالحمد لله وانس كملنا يعني 4 ويكس لسه ابتدى يعني حوالي 70 to 80% بقى نورمال. فده اللي بنقوله ان احنا وانس وما نقولش بالايج يعني. ده اوريدي حضرتك ريبورتد كمان حالات انا شفتها around 60 years with already الميوباثيك فورم اوف جلوتاريك اسيدوريا تايب 2، ودول بيحتاجوا لازم في الاول. ولسه جاي لي امبارح حضرتك السي كي نورمال، كان السي كي انيشيال كان 2000 وشويه. فحضرتك دلوقتي بنبتدي للبيشنتس دول نعمل لهم في الاول مايلد بروتين مع اوريدي الليبيد ريستريكشن. وانس ان البيشنت بقى كويس نبتدي بعد كده نقول نفتح الدنيا شويه. لان انا قلت له كنا بنحسب له وحدات ازاي بياخد في الاكل، قلت له بعد كده هنقول لك الدنيا كويسه وانس ان احنا عدينا البروبلم اللي احنا فيها. بس زي ما حضراتكم اتكلمتوا المينتنس امبورتنت. انا بتكلم على بالنسبه لي انا شخصيا انا عندي متبرعه ودي بقول لها على كل حاله جات لي قالت لي هي كانت هي واصدقائها اللي في الامارات وفي كل مكان بيجيبوا لي كل الفيتامينز اللي هي البي 1 والبي 2 البي 6 واوريدي من الذكاء عندهم من الذكاء. قالت لي الدكتوره علا انا بكتب لها كده على الواتساب اون ديلي بيزس اي نيد ذات. فبعت لها الولد ده وريت لها قد ايه ان هو يعني المان بقى مش الولد المان قد ايه بقى جريت. فقالت لي انا يعني نسجد ونشكر ربنا سبحانه وتعالى ان احنا كنا سبب في شفاء المرضى. فزي ما حضراتكم اتكلمتوا والمينتنس مهم جدا، لان تكون الدواء موجود او يكون ايفن الفيتامين موجود، ده امبورتنت للمريض. انا برضو فهمته من اول مره بديها له، بقول له ما تخافش، الدواء ده طول الفيتامين معانا طول العمر وهيكون موجود ليك، فقد ايه كان هابي يعني. وبشكر حضراتكم مره ثانيه.
شكرا للدكتوره علا. ودلوقتي السكند بريلينري سيشن اتفضل الدكتور محمد كمال حسين هيكلمنا على الادفانسنج دايجنوزس وتريتمنت والجينيتك اسسمنت. هي الميزه بس في الدكتوره علا والدكتوره ناجيه ان كل العيانين الصغيرين قبل ما بيجوا لنا بيكونوا شبعوهم فيتامينز، فيعني الحالات ما بتبقاش مسده قوي، لان كتير قوي من عيانين مايوباسي والسباينال حتى السباينال ماسكر واتروفي سباستيك بيبقوا واخدين فيتامينز كتير جدا.
First of all, thank you, Dr. Nagia, for giving us the chance to be here today, and thank you for all the attendees, and thank you for our chairpersons today. So the talk is going to be taking you a little bit away, like 5 steps from the clinic to the lab, to discuss the advances of the whole exome sequencing and where actually he landed us in neuromuscular disorder. Our agenda is going to be discussing the evolving of molecular techniques and impact on clinical management, importance of genetic testing, which revolutionized the diagnosis and the management of NMD, diagnostic and the clinical utilities of WES in the NMD. No WES test looks alike, and we will discuss that. Increasing WES diagnostic utility, different same goal. Finally, we will close with a case study and our take-home messages. Moving forward to our first slide, here's how the, let's say, here's the point. Okay, here's how the improvement in the technology have reflected actually a lot on our understanding and the practice for our cases. And actually, the last improvement that we have faced is the development of whole exome sequencing and whole genome sequencing based on the next generation sequencing. And from this moment, the marathon actually shifted from the technology to developing the data, to generating the data and understanding this generated data. Coming to the impact on the neuromuscular disorders, actually starting from the very early PCR like 1983, and then started to evolving discovery of the DMD gene is SOD1 gene, and moving forward, this actually have changed a lot our management to these cases and to understand how the disease is evolving. But the great things actually after the NGS involvement and the whole exome sequencing, that's our knowledge about the genes and the causing inherited reasons actually have been doubled in the last 9 years, from like 290 genes to 500, and then now we are discussing 650 genes involved in the neuromuscular disorders. So it's a little bit very clear how the improvement in the technology and the data generated reflected in our practice. Coming to the importance of genetic testing, why we do the genetic testing for the patients. So if we already have diagnosed it, why we do this kind of tests? The first one is to make sure of the diagnosis. Second is identifying carrier, exactly what just Dr. Ola just mentioned, that we have to know the other people in the same family if they have the same condition or not. Then also it helps in prenatal diagnosis and in PGTM. Personally, I have like 4 cases for DMD and 3 cases for SMN1, PGTM, successful cases, and healthy babies delivered. They ensure personalizing the treatment as what Dr. Nagia just discussed about. Each patient has to have his own drug based on his genetics, history, and evaluation. Finally, is the genetic counseling, what we're going to tell this patient about the report. So coming to the personalized era of the drugs, we have now 4 drugs for the DMD based on the exon skipping technology for the identified mutation, okay? So we have like exon 51, we have exon 53, and exon 45. So knowing the exact exon will actually reflect it on the drug selection. Actually, the very interesting thing is how fast is these drugs have been approved. It's only 3 years from the first drug to the others. So that actually translate the importance of the data generated and how is looking into this data collectively move our understanding to this kind of diseases. Moving to the second area, with the spinal muscle atrophy, we have 3 drugs now, and again, we are a little bit care about the timing. Because let's say in last decades, to get a drug approved and another advances that was taking like more than 20 years. Here we are discussing just 4 years. And here is the list. This is the coming, okay? There's a lot of promise coming from the gene therapy for the identifiable mutations. So it looks that the West already have moved us from suspicion to being a little bit more trusted for the diagnosis and how to manage the patient. But let's understand about West. Actually, West, in a very short words, it is a phenotype-driven analysis. So there should be a phenotype. We have to check our patient very, very, very cautiously and report every NDH phenotype, okay? Second, only the variants which are clinically relevant for your patient will be reported. So we do not report all the finding. Actually, we just report the findings that's related to the phenotype. We have here 2 words like diagnostic utility and the clinical utility. So actually, we describe diagnostic utility, how many cases, the ability of West to diagnose the case, to give you the reason behind this case. The clinical utility, how we will use this data to manage the case, okay? So for the diagnostic utility, it's reported between like 12 to 63, but that depends a lot on the experimental design. If just primarily were an inherited condition or not, because at a certain point doing West for all the patient is not the good thing. You have to filter the patient based on the patient history, the phenotypes, labs, radiologists, and everything. Then we decide if it is West case or not. We have a suspicion in an inherited condition or not. It's a little bit shocking slide. Not all West tests looks alike. So I don't know if, how that will be reflected. This is actually 4 kits of whole exome sequencing that's been in the market. And this is the performance. And not only like the competitors, but also the same vendor is offering like 4 kinds of whole exome sequencing kits. So when I order a whole exome sequencing test, I have to be a little bit aware about which kind of kit the lab is using. Why? Because this reflects a lot about the genes covered in this kit, okay? So I'm not aware of the list of genes, so how I judge it? Actually, there's a very, very, very known list of genes that comes to CCDS, RefSeq, and gene code, and you have to have all these genes in your West panel. Plus, we added to it the mitochondrial DNA. So you have to make sure that all the genes that you are interested to see in the exome panels that you are using. This is the 3 main classes highlighted, the mutations that could actually lead to neuromuscular disorders. 2 of them are pretty covered with West, but 1 is not, which is the repeat expansion. So whole exome sequencing, the good cat, okay, can give you the mutation in all the known genes, spike with the mitochondrial DNA, and they can give you a copy number variation image about your patient, if they have already a copy number variation issue or not, if it is a SMN1, 2, or whatever. But the thing that exome cannot cover is the repeat expansion. So if it is a repeat expansion suspected disease, think twice before ordering an exome. So to increase actually the diagnostic utility of the exome, we have implemented a certain kind of, let's say, algorithm, like we can improve the diagnostic power of the exome for the neuromedical disorders. Firstly, we have to make sure that the whole exome sequencing that we are ordered contains all the REF-seq genes, CCDS genes, gene code, plus mitochondrial DNA. Second thing is that they are reporting the copy number variation. Third thing is a comprehensive patient history retrieval. Actually, when I have an exome sequencing report in my hand and I just find that the phenotype was like myopathy, I do not continue looking to this report, because they have to actually write down every and each phenotype they have received from the physician, because that reflects a lot on the results. Third thing is actually, we have went through it a lot with Professor Dr. Nagia, which is the physician lab crosstalk. We have to talk together actually before we give the patient the final diagnosis, because at certain cases, not all cases, but at certain cases, there's something missing. We have to check it. So we have to call the physician have to call the lab, and we have to have this kind of conversation, because this kind of tests and this kind actually of disorder is not a straightforward one. It's not typical. Our first point is the phenotype revisit and with reanalysis. When we have to do actually a phenotype revisit and with reanalysis, we have two main points. We received a VOS report, and the second one, a negative results where you believe it's an inherited condition. Kindly, what you have to do is give a call, give an email to the, we will revise this case because we have revised the phenotypes, okay? So meet the patient again, evaluate him again, and send a new evaluation to the lab to get another reanalyzed report. And by the way, our case study today, we will highlight this issue. Fast comparison between the whole exome sequencing and the whole genome sequencing, we can see that after adding the mitochondrial and everything to the exome, we're just missing the repeat expansion and the non-coding variants. Well, actually, when I mean here the non-coding variants, it is the very deep intronic, because at certain point, the near intronic we see it. What is the bonus results comes with the WIS? Actually, it is the incidental finding and the carrier findings. So by the recommendation of ACMG, we have to report the incidental finding if the patient is consented. And the carriership actually goes for the carrier the autosomal recessive inheritance cases that the patient might have one of the alleles of it. So I can disclose something here based on Dr. Ola lecture. Actually, we have a very high carrier rate of PTD, pathogenic mutation, in Egypt. This data will be published very soon about the beta-allele deficiency carrier percentage that we already have discovered based on filtering the incidental finding in those patients. So kindly try to discuss with your patient that having the incidental finding in the report is something beneficial. Because a lot of patients actually get afraid of having this. I don't want to know that I might have cancer like after 5 years. At certain points, it's important to know. Different schools, same goal. So there's 2 schools actually in this area. The first school started like 3 years ago. they are actually convincing the physician to meet the patient, do the NGS. If it is positive, we are okay. If it is negative, go for tests, the labs, radiology, and everything, then reanalyze the WES. Okay, that might help a lot and have you a very early diagnosis. Okay, the other scenario is that you go with the scheme. Firstly, if it is identified case, you have to screen for a single gene. If it is negative, go with the gene panels. If it is negative, go with exome. If it is negative, go with genome. By the way, both are completely right, and you have to take your way. Both to the same goal. We will diagnose the patient. Our case study. By the way, this case is already published, okay? So we are not showing anything that's not published. And it is a very interesting case because this patient, 37-year-old man, Sudanese, positive consanguinity. To cut it short, firstly, based on this pedigree, apparently it's an inherited disorder, right? So all the affected are, all the affected were males, so they suspected at first position a DMD, and it was negative. So second position, they go with WES and was negative. So what they have done, a re-evaluation for the case, careful neuromuscular assessment, okay, and they have identified calvinopathy gene mutation in intronic region. Is it identified by WES? Yes. Okay. How many bases? It's a 29 base from the exome. So we cannot call it deep intronic. They call it deep intronic. It's not that deep, but still, it's like a 30 bases from the exome. We still can identify it. By the way, this case is very interesting and it already have been published because a lot of physicians in this position will go with whole genome, sorry. But actually, just reanalysis for the patient give us the mutation. It's a homozygous mutation in intron sex. So, kindly consider the reanalysis of exome data. Where is the world is heading now after whole exome and whole genome? Actually, it's going to be RNA-seq strategy for the muscle biopsy. For cases that we cannot identify any reason for it, take-home messages, not all WES tests have the same performance. Consider asking about the WES kit, what is covers and what is not covered. For VUS results, consider the re-evaluations, and H6 to 12 months. Cross-talking with the lab is very important. Negative WES results could be revisited after phenotype revision. Incidental finding and the carriership might help the patient. Kindly tell him to sign the consent. Kindly consider WES reanalysis. WES reanalysis can lead to a lot of improvement in the results after the phenotype revisiting. Finally, when you doubt anything about the report, kindly you are welcome to ask us on this email. Thanks for the team, and any questions?
طبعا ألف شكر دكتور محمد كمال على المحاضرة القيمة دي. طبعا الدياجنوز بتاع النيورو ماسكولار ديس اوردرز اختلف كتير في السنوات الأخيرة بعد الجينيتك تيستنج، خصوصا اللي هو الأكسون سيكونسنج. يمكن سؤال بس سريع كده، يعني تقريبا التكلفة بتتراوح من كام لكام لو عايزين نعمله العيان؟
Actually, it's around 20,000.
20,000.
Yeah.
فين في يعني معظم الأماكن ولا في؟
لا عندنا في المحل.
20,000. تمام. Any question دكتور محمد؟ أي أسئلة؟ دكتورة ناجية اتفضلي.
وطبعا بشكر دكتور محمد
شكراً
كمال
جداً.
على تعاونه معانا. انا تعاونت مع دكتور محمد كمال من 3 سنين في مكان اخر، فالنتائج ما عجبتنيش واتخانقنا، بس ما اتخانقتش معاه هو. ليه؟ انا بعتلك عيان انا مشخصاه ماسكولار ديستروفي، مش كده وبس، ده انا عارفه كمان السب تايب بتاعه، وعارفه ان ده كالبين، انا عامله له كلينيكال وعامله MRI، عارفه انه كالبين. اروح ابص لها الريزلت تطلع سيربيلر اتاكسي. I'm sorry I can't accept this. فلما اتكلمت طب ابعتي فول داتا، لا اتكلمي مع اللاب. ده اللي احنا رساله دكتور محمد كمان النهارده. الواس الهول اكزوم سيكونسينج ما بيشخصش حاجه، الهول جينوم سيكونسينج ما بيشخصش حاجه، حضرتك اللي بتشخص. احنا الاول لازم كلينيكالي احنا هنشخص، هنستخدم كل التولز اللي عندنا. اللاب السي كي البسيط ده بيشخص، الMRI ماسلز بتشخص، وبعدين بقول انا سسبكتنج كذا. ممكن اكلم اللاب اقول له ايه الاختبارات اللي عندك تساعدني. ممكن يبقى عايز يعمل مايتونيا ريبيت اكسبانشن، ممكن عايزه اعمل فريتراكس اتاكسا another ريبيت اكسبانشن، لكن ممكن اكون عايزه ادور على بوينت ميوتيشن في جين هول اكزوم سيكونس. لا خلي بالك ممكن العين بتاعك ده يحتاج هول جينوم. يبقى اللي انا عايزه بس اوصله، ودكتور محمد قاله لكم، هو الجينيتكس ما بتشخصش، الجينيتكس بتثبت اللي عندك. ولو لقيت لك ميوتيشن تقول لك بقى خلي بالك، زي الحاله اللي بعتها الدكتور علا، ده الباس واي داخل فيه رايبوفلافين، ده انا ممكن ادي رايبوفلافين للعيان واحسنه رغم انه عنده ميوتيشن. فهو ده اللي انا قصدته. لما بقى بدانا نتكلم مع بعض وبدانا نعرف بعض، على فكره نقابل بعض، وكانت الدكتوره شيماء من عندهم، ففهمت بقى. قلت لها انا الحاله دي كذا ودي، النتائج بقت رائعه، ووصلنا في تخفيضات معاهم الحمد لله، خدنا اسعار كويسه قوي، وبدانا نشخص عيانينا علشان السيرابي. احنا لازم نعمل دايجنوزس كويس، واللاب لازم يتكلم معاك، واذا الفينوتايب مش ماشي اتكلم معاه. هو مش هيعيد التحليل الجيني، هو هيبتدي يعمل ري اناليسيس تاني، واكيد النتائج هتبقى احسن.
صح. بجد يا دكتور اشكر حضرتك جدا جدا جدا، حضرتك لخصتي كل اللي احنا عايزين نقوله. والاكسبيرينس اللي الدكتوره ناجيه بتقولها بصراحه علمتنا احنا كتير جدا ازاي احنا محتاجين نتكلم دايركت مع الفيزيشن، لان ات سيرتن بوينت انا ببقى واقف على حاجه جين معين، الجين ده لازم يكون معاه حاجه في الMRI انا محتاج ابديتد MRI، فانا مش هكلم البيشنت الو بروفيسور دكتور ناجيه وبحكي محتاجين كذا كذا كذا. في بعض الدكاتره مش بيحبوا ده بالمناسبه، بشخص بالداتا اللي عندك اتس اوكي اسبير كذا 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 نيجاتيف ريزلتس، تمام، وبنكتب في الريبورت the data could be revisited upon providing 1 2 3 4 okay, so again it's a learning curve. We started to learn and we will continue to learn. We will never stop to learn actually. والناس بصراحه اللي بتشاين الطريق هي دايما الناس اللي زي دكتور ناجيه كده، اللي هو محمد تعالى نتكلم حاضر تمام. لكن by the end of the day we have reports from labs actually all over the world, Germany, USA, UK have the faults. Okay, so it's not about that the reports being interpreted and right in Egypt, but actually it's about the enrichment of the community, that's the discussion that enrich everything that we know, a new gene or a new phenotype that could be related or something that actually reflected a lot on the patient. And نحن لا نخجل تماما ان احنا نقول والله احنا we will amend this report, we will repeat this one, we will confirm with another lab, because by the end of the day there's a patient على المحك. Thank you.
شكرا
Sorry.
دكتور محمد. last question استاذ دكتور علا، اتفضلي دكتورة علا. اوكي دكتورة مها وبعدين الدكتورة علا.
يعني شكرا على المحاضرة الرائعة، بس أنا كنت عاوزة أسأل حضرتك على حاجة. هل أنتم ممكن تريبورت حتى للناشونال ريسيرش فاريانت؟
Actually, upon his request, in what we called a research report.
Okay.
So if the clinician asked for a research variant, yes, we do report. On another report, we call it research with report. Okay. The other thing is that I have a question yesterday about the benign variant. She asked me about by the way, there's a certain recommendation for benign variant in a certain genes, like in a BRCA and BRCA2. Okay. At certain ethnic groups, the variant that's benign in a certain ethnic is not benign in the other. So based on the gene, based on the finding, sure, we can provide whatever the report that you want. And one of extra service that we already have started over like 2 months ago, that we can reanalyze the other labs results if it is consistent with the kits that we are used. If it is contained the mitochondrial DNA and the same coverage, we can reanalyze the report. Thank you. Thank you, Dr. Mahmoud.
دكتورة علا ليها آخر سؤال، اتفضلي.
شكرا دكتور محمد على الجريت lecture. أنا بس I wanted to add with what you said a comment. يعني actually مهم جدا ان احنا not to neglect the potential relevant variant. هنبص نلاقي جالنا في الوس كاتبين negative results but potential relevant. I do have many cases which I just looked for potentially even I did for the other SIPs it came positive. فلازم نبص ليها مهم جدا جدا، دي حاجة. والحاجة الثانية re-analysis. يعني هقول حاجة simply كان في patient very X-linked adrenal leukodystrophy biochemically was positive clinically positive MRI findings وجالي already from X lab إن الريزلت كانت normal. فأنا already I contact I told them how come I need reanalysis فcame reanalysis positive. What I want to say not only for in the labs or genetics الكوميونيكيشن. يعني انا برسي استاذه الدكتوره ناجيه بتتصل بيا تقول لي وانا I'm speaking to the labs. فده مهم جدا لان احنا اوريدي بنحط داتا ايفن مع اوريدي كلينيكال داتا في الوس، فبتبقى نوت سفيشنت ان حتى ايفن لو هو از براكتسنج او هو دوينج التكنيك يبقى بالنسبه له يدور على ايه. فلازم مهم قوي الكوميونيكيشن ايفن فور هيستوري، دي هايلي كروشال للبيشنت.
شكرا دكتوره. هنقفل السيشنز البريني سيشن، ننتقل للنكست سيشن على ريسنت ابديت اوف ريسنت. ندعو النكست شير بيرسون استاذ دكتور محمود بيه هارون، استاذنا استاذ دكتور اكسم، دكتوره ساندرا. اتفضلي دكتوره ساندرا. استاذه الدكتوره ايمان خضر، اتفضلوا.